Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome to the June 2026 CoROM Conversations. My name is Aebhric O'Kelly. Joining with me are two esteemed barrel-chested freedom fighters, Bill.
Hello.
And Rhod.
Hello. How do I follow Bill's intro after that one?
I was too busy standing here being barrel chested,
So for this month, we are going to discuss austere primary care. I wanted to discuss something that we see more than anything else. Now, we all love trauma, right? Trauma is so easy. Just go through your CABCs. They live or they don't, right? I mean, it's just simple. It's the thing that keeps us busy is the primary care, the minor emergencies, the minor illness, the blisters, the whinging, somebody coming in to my clinic and saying, I don't feel well and I have no idea what's wrong with them. So that is what we're going to see the majority of the time. Remote, austere, resource-limited environments just means that we are working in places that are not easily accessible. Could be remote villages, could be offshore vessels, it could be working for an NGO or a humanitarian, or for those of you on the Eastern Front, there could be in conflict. We have current students and graduates who are doing that. And a lot of challenges is just lack of equipment, lack of drugs, lack of trained personnel, and delayed evacuation times, as well as environmental issues. And these are all things that we have to face. And these are the things that I love about our job. And it requires you to have a different mindset. And for those of you who've enrolled in our degree programs, you've already self-selected. You're already looking for this mindset. But for me, it was not something that was easy. It slowly, over the years, kind of dawned on me that there's just a different way of thinking from just being on a back of an ambulance in Seattle and doing a 20-minute per casualty interaction. And I started doing wilderness expeditions and remote Alaskan excursions, realizing that my mind had to change a bit. And part of that is your ability to address some of these stressors and some of these, lack of equipment and, dealing with the community, the team that you're with. So for me, it was something that I wish that I had our bachelor's remote paramedic to kind of walk me through that. It was something that I slowly kind of walked into. Bill and Rhod, what are your ideas on how to help people get that austere clinical mindset?
No, I would just say, I think you have to be comfortable with your ability as a clinician, or at least to the point where you don't stress over what the next patient is going to present with. You have to get to a certain level of comfort. And then at that point, now you have to induce some stress. And so if I know that I'm using, keep it simple, if I'm using this pen and I'm going to have to write everything that I'm going to do with one pen, what is my backup if the pen fails? And so do I have a pencil? Do I have another pen? Do I have another writing utensil? So if you do that, if you start thinking about how do you function in an austere environment, is if you find yourself relying on a certain tool or a diagnostic piece of equipment, how are you going to be able to accomplish that diagnosis or that evaluation or that test if that device or tool or piece of equipment goes down? What's your backup for everything? And then sometimes more information isn't necessarily better. If you have 5 pieces of data, which we talk about later on, setting up your kit, is that better or worse than having 20 pieces of data to make your decision on? Sometimes it makes us feel better, but it also adds stress. So, I think you have to go through this process of, do I need this tool? What am I going to do if that tool doesn't work or it fails on me? When the batteries will fail, they will. What is your backup? So you're just going through that mindset. And I think thinking about that too early in the process stresses you out too much. First, become a comfortable clinician, and then start troubleshooting it to learn how to be comfortable being uncomfortable. There's a slope in there.
I think that's really well put, Bill. You can get that cognitive overload of information, and actually what you really need to do is Billy basics, because if you get those bits right, everything else is going to flow on from there.
I think the mindset is something that has to be learned with, didactically, you can look into this, but for me, being in the back of the ambulance in Seattle in 99, 2000, and for me, a hardship is knowing that I have one nebulizer left before I go back to base. And that's my mindset. So that means that, okay, I know I've got another call. If he needs a nebulization as my last one, that's not much of a stretch of a mind, to be honest. And it wasn't enough for me. So I challenged myself. I went into the wilderness, did the WUMP, the wilderness upgrade to medical professionals, and then started doing some of these wilderness medicine expeditions because I wanted that experience.
I think that's a really good way of putting it as well, because you've got to kind of put yourself out there, hanging on the edge, but with an element of how safe can I be with this? Does that make kind of sense to the conversation? We go out into the Ulu and we can get away with stuff, but that's not how we should be approaching it. It's got to be that good, better, best approach to everything that we do.
Then it goes back to building your confidence. How confident do you feel in performing a task? How confident, not only confident to try to do it, and then confidence that you believe that you're going to be successful when you do this procedure. That's called self-efficacy, but no one ever uses that term. It's just, do you believe you're going to succeed when you perform a crike on somebody? What's your backup when this fails? So being comfortable with your own abilities, or even as a mentor, if you find yourself being a mentor to somebody coming in and they're learning, are you confident? The more confident you are as a mentor, you're going to let that medic try things because you realize that if they mess it up or go awry, you're so confident in your abilities that you feel that you can recover what's going on. So you're allowing that med student or that medic that's learning under your tutelage, you're going to allow them to try that. They're going to try more and they're going to have better experiences, in that process. So I think you need to get to the point where you're the mentor and you're confident that you're going to let a medic do something that if they mess it up, you can recover the thing without having too much of an adverse event going on.
It's the clinical placement. It's the clinical experience that's going to help you get this as you go forward. Andy, you have a question.
Not a question. It was just my contribution that as well as, having the right mindset, you've got to have resilience in there. You've got to be able to, as Bill said, you've got to be comfortable being uncomfortable. So you're able to keep going when the chips are down. And quite often the medic is also the backbone of the expedition. You've got everybody coming up to you with their woes and, they're homesick and this and that, and they've got a blister on their little toe. And, there's a whole multitude of different things, and you've got to be able to deal with all of that.
Yeah, good point. Good point. There's a whole bunch of problems that we need to be able to deal with. We need to have the adaptive thinking. We've talked about that. And now we have the skills that we need. So first up is common ailments, So traveler's diarrhea, dehydration is common, respiratory issues, malaria, dengue fever. Malaria and dengue fever aren't as common, but at the college, we think everyone has malaria until proven otherwise. UTIs are very common for travel. Soft tissue, injuries, wounds. So you have cuts and scrapes. And we always get cuts and scrapes, but in a clean environment, we're not having issues. But if you're doing this in the jungle that's wet all the time, your minor blister, your minor scrape is going to become a big problem. So blister management is a big part of austere primary care, taking care of cuts and lacerations and wound infections. Other skin problems like fungal issues, contact dermatitis, cellulitis, a lot of derm. And in our austere primary care module, we have a whole module on derm, on skin. There's so many things that are skin problems that we need to be good at. And as a critical care paramedic working in the city, I really don't care about skin. I mean, 30 minutes to get a ischemia from someone lying on my stretcher, I don't have them for 30 minutes. I turf them off in 20 minutes, and I don't have to worry about these long-term problems like the skin. So if you're not good at derm, you need to be better. Environmental problems, so hypothermia, frostbite, heat exhaustion, heat stroke. These are environmental issues because we are working in environments that are environmentally challenging. So if you're not good at assessing hypothermia and frostbite, if you've not done the research on how well does ibuprofen work for frostbite and seeing the current WMS guidelines for frostbite or for HACE and AMS, you need to be better. You need to do better. So environmental issues are a big part of austere primary care. How many of you can strap an ankle? And I'm pretty good at it, but I'll be honest, I'll raise my hand. It's been 3 years since I've strapped an ankle. So am I good at it anymore? I am not, because you need head knowledge and you need hand knowledge. And if you haven't those, you are losing cool points. So be very good at ankle sprains. On the ODAs and special forces, we had so many ankle issues. And you could be rolling an ankle, and then it could be a tendon strain, or it could be a whole bunch of different things. And we need to find out, is that I mean, I don't know how many hairline fractures or minor avulsion fractures I had on special forces. And we had to assess, all right, do I call the helicopter or not? And you need, as an austere provider, you need to know ankle injuries really, really well. And the same with knee strains and dislocations. Like I've put 12 dislocated shoulders in my lifetime, all of those in the Army. I haven't done it once in the civilian side. So how comfortable are you with dealing with fractures and dislocations, or even just some minor cramps and spasms? How well do you know musculoskeletal injuries, and where can you go to get this experience? Bill, Rhod, what are your thoughts on musculoskeletal injuries?
Well, for me, the biggest level of dislocations that I've come across has been when I've been working in the past on like adventure med stuff, particularly kayak injuries. That seems to be a big one with shoulders going, and then mountain biking, people going down, dislocating that way. That's probably the biggest set of circumstances that I've come across those. Certainly not in a tactical environment at all.
I think it's just when you're learning whatever system or whatever rotation you're doing, you want to go into that rotation and learn how you would function. You want to learn all the stuff in that rotation as though you're going to work in that area when you get done. So, when I did the OB, knowing I would never work in OB intentionally, but my approach during that rotation was to train me as though this is what I'm going to do when I finish my rotation. You're going to hire me. So you want to have that mindset when you're learning it. How do you really apply it as though a person that does this every day does it? So you don't want to memorize it just for the test. You want to memorize it for that. All you have to do later on is pull up a quick video and see somebody else do a demonstration, and that triggers that memory, that muscle memory that you have that's transferred from short-term to long-term memory, that you can kind of pull it back up. My whole youth was spent playing sports, and so I've experienced most of those orthopaedic injuries. So I have a personal connection to all of those and how you repair it. So I know bad ways to do it because it was, done to me that way, or I've initially done them wrong, and then, learning better as you go. I think just trying to transfer these skills to long-term and practice them so that you can do them being woke up at 3 a.m.
Are you actually going to try and reduce a suspected dislocation in the field? Are you going to hold it because of your time, distance? What's your medication from a opioid point of view, pain relief, etc.? You've got to balance all these things, and there ain't no textbook for that.
Yeah, good point. So ears, nose, throat issues, dental. It wasn't until I started working at the college and getting Berger Langdana in to teach our class, and me being in the back of his class 3 or 4 times now and listening to him. This is how I learned. I did this with Doc Hagman for 7 years, teaching live tissue and the OEMS course, hearing him speak again and again and again. And for my thick skull, that's how I remember it. But getting the understanding of dental issues and eye issues and ear issues or bites and stings. These are definitely things that you need to be very comfortable with. As a paramedic working in the city, I didn't have to deal with these things. Oh, you got an eye problem here. Let's just cover that. Don't care. Don't really care at all, because in 20 minutes, I'm going to send you to a doc. So we don't have that choice in austere environments. We need to be okay in each one of these obscure types of things. So you're in a jungle clinic in Eastern Africa, and you have someone that's you're setting up an austere clinic, and you need to come up with a concept, a way for you to deal with someone who walks in on you. And so being able to quickly assess life threats, determine how severe they are, get differential diagnosis. So at the college, We have a minimum of 5 differential diagnoses for everything. And if you don't have 5, when I teach my BSc and master's students, I'll wait. I will just pause the class until everyone has at least 5 differential diagnoses, and that keeps you from being blinkered. And then you do treatment and you do disposition. But I just had a hard time remembering all this. So in the Army, we were forced to use SOAP notes. And I won't even ask Bill to kind of go through the whole SOAP note thing because I don't remember it. It's just objective and subjective and Gestalt concepts. So I used those 4 parts of the SOAP notes and I've turned it into 5, used the chart mnemonic. And I've been teaching that at our college for a while. And I've watched a lot of medics, paramedics, because this is a year 2 thing that we teach our bachelor's degree students, that they'll come into our TTEMS course, our Trop Med course, Expedition Medicine course, and we'll use this chart mnemonic on how to assess this casualty. So let's go through this. The C in chart is chief complaint and condition. So as they walk through the door, or no, wait, you're in a jungle. So as they walk towards your hammock, because your hammock is off to the side, because that's your clinic, your kind of give some space and privacy for people to come in. Someone comes over to your hammock and they are going to have a chief complaint. And so instead of saying, okay, what's wrong with you? You can come in and you can say, all right, why are you here today? You don't need to be rude. Just say, oh, why are you in my clinic? And that will give a chief complaint. And then you need a quick condition, meaning, are they sick or not sick? Over the years, I've been in EMS since '89. I kind of can look at somebody and get a feeling on, are they big sick or little sick? But when you first start out and at 3 a.m. when I'm being woken up, that skill might not be there. So I use a quick CPRO assessment, and CPRO is our primary vital signs at the college. And it's easy and quick because all you need is an SpO2. So he comes in, so why are you here? Okay, we have a chief complaint. So as he's telling me about that, I whack on an SpO2 monitor. Now I have oximetry. I have the pulse rate. I can get the respiratory rate very easily. And then the cap refill, central cap refill, I have my CPRO. And that gives me a hemodynamic monitoring of this casualty. I know, is he big sick or little sick, just from the CPRO. When we teach PEP or PALS, we use the pediatric triangle, which is really clever as well, that gives you a very quick assessment. Bill or Rhod, what is your trick on determining big sick versus little sick?
It's that doorstep diagnosis, isn't it? But that's so built on experience and what you've seen, pattern recognition, blah, blah, blah. But I will always go on. If it don't feel right in your gut, then there's something really, really wrong and you need to investigate further. One of the best things I've done this year was the AMLS in Malta back in May. Because for me, I've done so much trauma medicine in the last dozen years or so. To get back to doing medical stuff was great. And it just gave that very systemized approach, how you should go through it. And as Aebhric said before, he wouldn't let us out of his sight unless we came up with 5 diagnoses, which as a paramedic, we're generally not allowed to do.
I like your quick gestalt kind of assessment. I try to combine it into ask them a simple question or say a joke and see what their response is. Respiratory, I think I've completely taken off my level of concern because if I can see them breathe, then it might have a respiratory component. It might have an anxiety component. It could have pain, all of those things. But if I can't tell if they're breathing, meaning I know they are because they're awake and they're alert and they're talking to me and everything. But if I can't count their respirations, they don't have a respiratory problem. So I almost just take that off the table just by asking them questions. And then whenever they're talking to me, do they have to pause to breathe? Do they have to take deep breaths? Those kind of things. So it's an ongoing assessment, but hopefully at some point, depending on if I'm in a clinic setting or if I'm in the austere setting where I'm the receptionist and I'm the clinician and I'm the diagnostic lab person and I'm, all of those things, chief cook and bottle washer for patients, then I like the idea of slapping the pulse ox on there. I've tested myself over the years where if I want to just check the rhythm of the pulse, where I can check a pulse and without counting, using a tempo of the pulse, can I calculate what the pulse is before the pulse pops up? So you generally got less than 3 seconds to kind of see what that rhythm is. So can you tell from the rhythm of the pulse what the pulse rate is? That's kind of a fun trick to play on that. But I like that initial thing. If you ask them a nice complex question and can they put together your thoughts? Your mini neuro is, did they hear what you say? Did they process it correctly? And did they respond appropriately? You've just done a mini neuro right there. So you don't have to overcomplicate it. And of course, if there's any deficit, you're going to explore those deficit wrong answers or complications. But
So that's the chief complaint. Now, the next is the H, which is history. And we use sampler and OPQRST. So we're used to that in EMS, except we have an R. We added an R. And austere environments, you always have an R. And that R in sampler is recent travel. And the reason for that is if I am in the back of an ambulance somewhere in Europe and somebody has a fever, I needed that R on recent travel. Did they recently come from the Congo? Or a cruise ship in South America that had this huge hantavirus problem. So when I go through my sampler, it's the same as EMS anywhere, but we add an R. And Rhod, I'm glad you mentioned AMLS. I'm a big fan of that now that I'm teaching that. They have an R as well, and that's risks. And I like that. So our sampler now has two different R's. One is recent travel. One is risk factor. So does this patient have a risk factor? Are they asthmatic? And they have a respiratory problem, even though they're not showing as asthmatic attack at the moment. And then the OPQRST for pain. So history is really important. Oliver Wendell Holmes said that 95% of medicine can be ascertained with just a history. You can get pretty much everything you need from history. Rhod?
Yeah, I was just going to jump in on that recent travel history one and how important it can be. I popped a little piece up about some CPD I'd done on LinkedIn yesterday, and a clinical colleague from Scotland jumped in to say they'd had to review somebody arriving into Edinburgh that was displaying signs and symptoms of potential Ebola. So, with international travel, it's really important that we start taking that into consideration.
Good. So that's the H in charts. So let's go to A. So assessment. We have time now to take time to go through the secondary vital signs we call BEAST. So CPRO is our primary vital signs at the college. Secondary is BEAST, and they just take a little longer to get. That's why we whack on an SpO2 right away as they walk in, but it takes a while to get BP out and everything else. So that's under A in chart, and we'll go through each one of these. So BEAST. So blood pressure, ECG, AVPU, and GCS, sugar and temp. So these things are important in austere environments, BP and MAP. So let's not forget MAP. You want a critical casualty assessment. MAP is one of the best out there. ECG, and I've had some good conversations at conferences where people are not really understanding why we have an ECG. And in austere environments, we do need that. We need to look at that T wave. We need to look at the ECG, and even a 2-lead ECG is fine. And the other comment is, well, I'm not carrying a LifePak 15. I'm not either. But I do have an ECG that's the size of a deck of cards, or even my watch. So I was at a conference in Poland, and this lady collapsed right in front of me. So I took my watch off, put it on her, and got a rough ECG, knowing that I could at least rule out a major problem. Is it definitive? No, of course not. She went to the hospital because she had loss of consciousness. But immediately I could see if it was cardiac or not. So everyone gets ECG. There's no excuse for you not to have an ECG with all the kit that we have. AVPU. So we have, for alert, we have AVPU, we have alert oriented times 4, and then we have GCS. And it takes a while to get GCS. I'm not fond of GCS because we have 11 people in the room right now, and we'll get 11 different GCS scores on a casualty. So that's good for head injuries to trend, and sugar, everyone gets sugar, everyone. And same with temperature. If you are in an environment where you don't think temperature is important, think again. So we use BEAST. Any discussions from Bill and Rhod?
No, I like the mnemonic. You might not apply, like, how do you take a blood pressure if you don't have a BP cuff? Can you do peripheral and central pulses to look for, rate and regular rhythm, strength and character, all those. ECG, it's nice if you have it. What if you don't? That's the going back to the very first thing is learn how to be comfortable being uncomfortable. Yeah, you would like to have that information, and that's another data point. But what happens if you don't? The AFPU is free. You can just talk to them. I think getting into the finer points of the AVPU and the Glasgow Coma Scale, I've memorized and forgotten the Glasgow Coma Scale details so many times. It feels like just a rep for a PT test or something. Everyone knows what perfect scores are, and everyone knows what one is. So what is the second and third scores for the Glasgow Coma, and know how to tell the difference between the two. That's where you spend your time, and that's going to give you the key. And I think documenting a GCS or AVPU is trending that over time. Is it going in the right direction? Is it going in the wrong direction? So no, it's a great mnemonic. I like it.
Good point. Trending is everything. It should be tattooed somewhere. So the R in chart is review of systems, and I use the mnemonic cranes. You don't have to remember that. It's just I like using the big thick problems first. So cardiovascular, respiratory, abdominal injuries, problems. So in our field guide, we have a assessment system for each one of these that you can test, clinical tests, diagnostic tests, to see if there's a problem with any one of these. Bill, as a PA, you've probably done these tons and tons of time.
I think focusing on what they're there for. If you're doing, this is a great review if you're doing a complete physical on somebody, but if you're doing point of care, chief complaint type medicine, you won't do a full one. You might do a cursory just to make sure that there's no associations, but a lot of it is just going to be going down the rabbit hole of any deficiencies or abnormalities. It's kind of exhaust that versus, going through all the normals. I think I've said this before. I have the same physical exam for somebody coming in for a sprained ankle as I do for somebody coming in with a Halo Scuba physical. I have the same physical exam. That makes my charting easy. And that's how when I'm working in the ER, I can go through and I can see 3 or 4 patients and then come back and chart on all of them, because all I have to do is remember what the abnormalities are, because I know what my normal is because I've been doing it for, decades. So I think that's the thing. Really come up with a really good physical exam that you do on every patient that you don't think anymore. And it makes it easier to know the abnormalities, and then just follow every abnormality down to the end.
So the T in chart is treatment and disposition follow-up. This is where we will document what we've done, the treatments, the differential diagnosis, the 5 diff diogs, and put this into an ATMIS form if that's what you use. We use it at the college because it's ubiquitous now. Everyone uses ATMIS, but the T is trending as well. So make sure that you check your casualty over time. So in a clinic, I found chart to be easier to deal with than SOAP notes. So diagnostics. So we have toys in austere environment, and with technology breakthroughs, the toys are getting smaller and smaller and better. So there's zero excuse for you as an austere medic to not have some of these abilities for diagnostics. So first and foremost is malaria. So you will always have an RDT for malaria. And as a trop med guy, I have 2. And I have 2 different RDTs to look at 2 different proteins on the merozoite of the falciparum malaria. And the reason is that the RDT has a 5% failure rate. And I'm just unwilling to let 5% of my casualties die a horrible death because I'm too lazy to carry another RDT that weighs nothing that will look at the HRP2 protein instead of the HLD protein. So that way my chances of missing a falciparum malaria is minimal. So always have 2, unless you have the ability to do microscopy. And I'm an avid fan of malarial microscopy, but only since every year I go to either Liverpool or London, and I spend 2 or 3 days on microscopes because you need to be that current. So dengue fever, there's an RDT for that. There's RDTs for influenza as well. And we got to look at the diagnostic thinking of each one of these primary care problems and what do we have to test for this. Some of them are clinical tests. Some of them are laboratory tests. And we need to be very good at using these tests. But you were born with some of the best medical kit, right? Your brain in your hands. All right. So we did talk about some kit. Let's go through Austere diagnosis kit. So pulse ox, we talked about that. Glucometer. So no one mentioned point of care testing, and glucometers are so small, lightweight, and cheap nowadays that there's zero reason for you not to have it. It's good for sugar levels, but it's good for malaria as well. It's good for someone who's hypothermic and they're shivering so much. What level of glucose do they have left because they've been shivering and using it all up? So glucometer is good for austere environments. Urine dipstick is really important. And yes, we use it for the 11-point urinalysis, but we also use it for fecal blood. So you can stick your dipstick into fecal matter, 3 different places, wait, and it'll show blood or not show blood. And then that changes your diagnosis of diarrhea from diarrhea to dysentery. And once they have dysentery, they are in a big bit of trouble. So urine dipsticks are really important. We talked about malaria RDTs and the fact that you always carry 2, and ultrasound. So, Bill, I know you love ultrasound as much as I do. Do you carry your ultrasound probe in austere environments?
I've had them. They're great. They're a multi-purpose tool. They do way more than one thing. But kind of going along the lines, I mean, all of these are good to have. What's your backup for every one of these? You know, if your thermometer doesn't work or it measures off, what's your backup to test it? What can you use the back of your hand? Can you use, what is your technique to checking somebody's temperature? Same thing with pulse ox, blood pressure, right? What's your backup to every one of these tools? Like you should have 1 or 2. I'm not going to go as high as 5 options like you would for your differential, but I would say what's your backup for every one of these diagnostic tools? Right? Thinking about it in real time is going to be challenging, but think about it before you go in.
So that's part of your rough truck, house, and plane. So on your person, I'm going to have my ECG and maybe a pulse oximeter or something that's really lightweight. Then it'll be in my ruck, and another one will be in my truck, and another one will be in my house, which is my clinic. So, but yeah, how deep do you want to go? Are you going to carry 3 different thermometers? If you're in a yeah, why not? You'd have one yourself, one for your ruck, one for your truck, one for your house.
They're dirt cheap. You have a nicer one for your clinic that's got the IR where you just shoot it at the forehead. Those things are amazing.
Yeah, the tympanic ones are great, but that's definitely in my house kit. It's not in my ruck or my truck.
And believe it or not, I mean, some of these run hot, some of them run cold. If you get the first temperature and it's off, like how do you validate that? Do you take your own temperature?
Yeah, that's a good point. Or several people to get kind of a baseline.
We've done it all the time in the courses where you check a temperature and it's like, I don't think their temperature is 92 Fahrenheit. So how do we check that?
That's a good point. Like SpO2, if you're in an austere environment with elevation, the first one I take is myself. And I've been on here in Germany, it's the Zugspitze is way up there. And every time I go to Zermatt, I bring my SpO2 meter just to check myself. So it's like 84%. And it's like, well, I'm walking around and I'm mentating somewhat, normal, but
Subjective measurement.
subjective measurement. So it's 84 on me and my casualty is going to be 84. So are they big sick or little sick? Well, that might not be a bad measurement. What was really cool, last time I was in Zermatt, I put the SpO2 in my finger, it was 84%, and then I did pursed lip breathing, and I got it up to 90. And pursed lip breathing is, I did the research on it. There's PubMed studies showing it's 2 PEEP. It's not 5 PEEP. We need 5 PEEP, but it's 2 PEEP, and that helps recruitment.
Yeah, it's breath holding. Same difference.
So let's talk about fever. So there's going to be tons and tons of differential diagnosis for fever.
I'm not going to talk about causes of fever. I'm going to be talking about how to measure it appropriately.
Sure.
In old people and young kids, those infrared and tympanic and temporal thermometers do not work. They're not accurate. You need to do a rectal temp. Now, I know nobody likes it. However, if you're really looking for a fever, do it the right way. Do it the right way first, and then you can trend it with those other thermometers. But in my experience, a rectal thermometer temperature on an old person or a kid is the only way to take a temp. And that's a nurse perspective.
So, Angie, let me ask you about our armpit, the axilla. So we use that. Is that not going to be useful for peds and old
Again,
people?
I think that an axilla temperature is fine if you're trending the temp, but for your initial temperature, it either needs to be under the tongue or in the bum.
Fair enough.
Period.
Fair
End of story.
Yeah.
And nobody wants to embrace that anymore because it's easier to do a tympanic or a temporal temperature, but you will miss a fever in an old person every single time. Every single time.
And under the tongue in a cold environment isn't the best either.
Nope. But if you put it in their bum, you're going to get a core temperature.
You have your 5 differential diagnoses for fever in austere environment, and then you need to come up with clinical tests to start differentiating that diagnosis. So it always be fastidious with fever of unknown origin in an austere environment. So it's hard to talk about primary care without talking about hip and sheep vomit. We're dealing with a casualty for extended periods of time, and you need to be very, very good at nursing care. I wish very much I started off as a nurse in the mid-'80s instead of going straight to Sheriff's Academy and then Special Forces. I would have been a lot better than I am now, but so I'm catching up. And I encourage everyone listening to this to be better at nursing care. I wanted to talk about public health real quick as well, that being an austere medic means that you're making sure that the water is coming from a good sanitary location and your toilets, your fecal matter is going somewhere else, hopefully downhill from where you want to set up your camp. And preventative care is the best medicine. Be very good at preventative care. As you go off on your adventures, you're hired as an austere medic for this group. Everything you see is going to be primary care. Make sure they have their vaccinations, make sure that you get vector control and infection prevention, which is, Semmelweis was right 150 years ago. You need to wash your hands. Red flags. So at the college, we're very fastidious about looking at red flags. And in our field guide, we have a page dedicated to red flags on each of the systems. We have general red flags. We have ears, eyes, nose, and throat, respiratory, or cardiovascular. So I like having all these red flags on one page. So at 3:00 in the morning, when somebody wakes me up on my hammock, I'm half asleep, it's raining, and I didn't get sleep. And now they're shining a torch in my face saying, hey, I don't feel good. I don't feel good. I don't feel good. I can have this red flag in front of me to quickly ascertain big sick versus little sick. So key takeaways: be good at primary care. If you are not good at primary care, find somewhere that you can get that. And it's head knowledge and hand knowledge. You need both. Make sure that you prevent before something gets out of hand. Use our chart mnemonic if it suits you. Use our chart mnemonic to make sure that you don't forget each part of the primary care assessment. Be good at nursing care. Assess your limitations. Mitigate those limitations before you deploy, and evacuate early. And we do have a austere primary care CPD online course. I designed it for this 10th Special Forces group. Guys, they hit me up and they say, hey, we need a DNBI course, disease and non-battle injury. So I put this together, and it's now available for anyone. But primary care, you have 2 choices. You can be good at this, or you are losing cool points. Any questions? Or Bill, Rhod, do you have input? Or Angie?
No, I like it. I told you beforehand, I really appreciate how you put this together. I think the imagery and icons and the organization was spot on. Looking at something, seeing things that I feel pretty comfortable doing primary care in an austere environment, but looking at it through somebody else's eyes keeps me in that lifelong learner status. I think this was a great organization. I like it.
I think in austere and non-austere environments, God gave you 5 senses. Use them all. When you go into a patient or see a patient or go into their room, you can do a 10-second assessment from the doorway and say, you're sick, you're not sick. Use your senses. If they smell funny, there's a reason. Go find that smell. If they're sweaty, there's a reason. Go find the sweaty when you touch them. People, I think in this day and age, I'm not going to say that tools aren't fantastic, because they are, but I think sometimes we forget the art of patient care and touching a patient. We got to get back to touching people.
I go back to one of my earlier comments, Angie, and that's that doorstep diagnosis and trusting your instincts. And there is the old adage of treat the patient, not the machine. We overlook that basic sight, smell, touch.
Listen to what they're saying. Listen to what they're telling you. That right there is half the battle. Half the battle is just being quiet and listening to people, because you always want to interject. But if you're quiet and listen to them, sometimes for me, I find more things just listening than actually doing.
Yeah, and how do they self-present as you walk through the door,
Yeah, absolutely, Andy. It is that. Yeah, gut feeling. Don't override it.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.